presentation will be from Neurosynaptic. Mr. Samir Savarkar, Chief Executive Officer of Neurosynaptic, is going to present low-cost healthcare models. As you know, this session theme is low-cost healthcare models. So Samir, and 15 minutes. You can reduce the talk also. Right.
Hello, can you hear me?
Yes.
I hope I will be able to, I will not put you to sleep. I am Samir, I represent Neurosynaptic Communications. Let me start with something which almost all of us know, so that it's not an unfamiliar territory. So, as we know, there is or even before I begin, I would like to actually acknowledge something and thank something, because the very reason why we exist here today and I am making a presentation here today is because of some of the contribution, invaluable contribution that some of the members of Telemedicine Society of India and Telemedicine Society itself has made in our existence. I would notably like to mention Dr. Ganpati first, who has been instrumental in validating our solutions in the initial stages, Dr. Selva Kumar of SRMC, who has been involved with Mr. Satyamurthy in assisting us, helping us to get the TDD assistance for commercialization of the technology, as well as Mr. Satyamurthy even further throughout making sure that we don't deviate from the strictest guidelines that we have in the industry for the medical devices and solutions, and at the same time pushing our case very strongly with the government departments for the telemedicine as a whole to take off. So I really would like to take this opportunity to thank all of the people involved in Telemedicine Society of India, because that is the very reason we exist here today. I would start with, we basically will look at rural healthcare related issues concerned with telemedicine, because that's where most of our experience comes from. As we all know, there is a huge rural urban divide in access of healthcare. There is a cost issue where people who can access have to pay much more than what you and I urban can actually actually pay. Availability is a very big problem. We have quality, which is a huge issue. And though people prefer, and I think Luke already pointed that out, there is a preference to private care due to quality, but of course limited by affordability. As the care goes higher and higher, we see that people start choosing public healthcare facilities a little more often than for the primary care. The extent of problem is such that over 20 million Indians are pushed below poverty line every year due to only the healthcare expenditures, and all of those are actually borrowed money or taken loans and so on. 40% of hospitalization actually comes from there. As we know, the government is the largest organized healthcare provider with about 20% share in the rural healthcare space, and private care in the rural areas is basically dominated by unqualified practitioners, or as we call as RMP, or you name it, right from traditional healers to DIs to ANMs to a range of practitioners, compounders. And 80% of the need is for primary and secondary healthcare, whereas as we saw in the previous one, there is a very clear divide between the demand and supply of healthcare. Where there is least demand, there is more supply, and vice versa. So, can telemedicine bridge this divide for rural India is what the question Neurosynaptic started with. And we have specifically set up with a mission to enable access of quality healthcare in the rural areas with the help of technology. So there are, of course, connectivity issues. We have lack of trained health workers. We have affordability and usefulness to villagers. What kind of solutions we need to provide? Most importantly, now these were some of the things that we already knew. But what we came across in various experimentations that we did was an end-to-end healthcare delivery is an absolute must for giving a complete experience of healthcare access to the population. The cultural acceptability, of course, who is the healthcare provider and whether it is the same person that they talk to who they have been talking to earlier. There are severe medical legal issues in the ground, and there are viable business model questions, of course, which are bothering everyone. So, what what we did as a first step was to build an equipment and a software, a basic software. That was our starting point in the whole thing. This was in about 2005 when we actually developed this device and first version of solution. It measures multiple parameters. It works on lowest possible bandwidths like 32 kilobits per second with real-time audio, video. The whole belief has been to make the solution work on infrastructure and skill set that is available at the ground level in the rural areas. And so we basically broke the cost barrier, we basically broke the connectivity barrier, we basically broke the power barrier. This whole equipment works on 2 watts. You just connect it to USB, it starts working. But we realized sadly this was not enough. As we went into the field and experimented with all kinds of business models to figure out how operational models, business models, who will provide the service and all these things, we realized that we needed an entire set. So today the solution has more or less evolved as a platform which accommodates various doctors, village health centers, pharmacies, diagnostic labs, hospitals, mobile health workers, all in a distributed sense. And a central medical facility which is more like from where the doctors provide the consultation, paramedic takes down the case sheets and so on. So, and I'm going to play now a small video which actually would demonstrate one of the models that has been in functioning since last 3 years on the ground. And this is quite a scale that it is functional. Audio? I think we don't have an audio. I'll let this audio.
From the world, followed by campfires, a lot of others in between. The Indian village folk, such as Amina Bibi and her husband Nazir Khan here, accessing quality health care usually means traveling long distances to the nearest city doctor's clinic in a variety of convenient modes of transport. On an average, a person in an Indian village travels perhaps 15 kilometers to access a doctor at a private clinic. Healthcare takes away a lot of time and precious resources from such people. They often have to make follow-up visits. The other and quite a common option for people in the villages is finding a local provider. Krishna here has brought his friend Anil to one such person who is not formally trained and who offers treatment that may be unreliable or even unsafe. Each year, over 1 million Indians, mostly women and children, die only because they didn't have access to quality health care.
ब्लड कल्चर हो ना, इसकी रिपोर्ट आपको 1 हफ्ते में मिलेगी सर। 7 दिन बाद आना पड़ेगा मुझे सर, आपको फिर आना पड़ेगा सर।
How does one link various private sector skills located in a vast area and make markets work for the rural poor? This is the challenge that World Health Partners addresses.
World Health Partners, WHP, is a young organization working in rural India with a network of doctors and frontline health workers.
WHP's strategy is simple. Divide service delivery needs into smaller components and match these with skills that are available close to the patient. Whenever local skills are inadequate, the patient is referred to a higher level of care. Since all the providers belong to the same network, WHP is able to ensure maintenance of quality of care. In each of the project villages, a woman entrepreneur and her male partner are networked into either a Sky Health Center or a Sky Care Center. This Sky Care Center is at the bottom level of WHP structure. It sells over-the-counter products like condoms and vitamins, or services like rapid pregnancy tests. It also serves for referral. Amarpal, a small farmer, has brought his wife Kamlesh to this center in his own village. Savita is the woman owning it. She has prepared a referral slip for the couple and has guided them to the higher level, the Sky Health Center. Savita does not charge anything now, but will get a commission from the Sky Health Center later. Amarpal and Kamlesh now visit the Sky Health Center, located about 3 kilometers from their village, Hamidpur. This center has a teleconsultation system, which enables a local patient to consult a doctor in the big city. Here the patient is charged a small fee, roughly $1 for consultation. If they have a government-issued poverty card, they pay only 20 US cents, with WHP absorbing the subsidy. Patients can also visit a Sky Health Center directly. Each center uses the latest advances in satellite and communication technology. Every Sky Health Center is owned by a woman entrepreneur who works with her male partner, usually her husband. The couple set up the center with their own investment and at times with a loan from WHP. Though the education levels of the owners are low, the training that WHP provides gets them competent enough to register the patient and create an electronic medical record. Upon registration, the central facility takes over and a team of counselors and doctors attends to the patient. The doctor is able to get vital signs like pulse and blood pressure and use instruments like stethoscope and cardiogram through the system and write a prescription. For female patients wanting to discuss confidential details, the project ensures that the counselors and doctors attending to them are always women.
देखिए बिना जांच के हम कुछ बोल नहीं सकते तो बिजनौर में जो एप्लिकाइनोलॉजिस्ट होंगे तो उनको आप एक बार दिखा दीजिए उनको.
Once consulted, the patients or their attendants can buy the medicines from a nearby pharmacy. The project maintains a strong supply chain and sells generic medicines under the brand name Sky Meds that often cost 20% of the branded products of similar quality. The project also markets subsidized family planning products. An interesting component of the WHP project is the partnership with the public sector. Every 2 weeks, a nurse midwife from the public sector visits the Sky Health Centers to insert IUDs and administer contraceptive injections. She also uses the instruments to trace reproductive and gynecological infections in consultation with the central facility doctor. Special devices, including a long-corded webcam, enable the doctor to visually examine the client in complete privacy. The doctor has prescribed some tests for Amarpal's wife, Kamlesh. She, however, does not have to travel to the big towns where the diagnostic centers are. Instead, a sample collector visits the Sky Health Center once a week on a predetermined schedule. Reports are delivered electronically to doctors at WHP's central medical facility. So, on follow-up visits, Kamlesh will find her test reports already available with her doctor, who can now improve the diagnosis and treatment. Rural and low-income patients like her thus no longer need to make repeated visits to town for tests or report collection. There is, however, a limit to what such a teleconsultation system can handle. If a patient, such as Kavita here, needs to be physically examined or to be surgically operated, teleconsultations cannot address the need. The project has networked formally qualified general practitioners and specialists available in the big towns surrounding the villages as franchisee clinics. The project promises these clinics large caseloads from rural areas. In return, it negotiates substantially reduced rates for services. The electronic medical records are available to the franchisee physicians on a need basis. The general practitioners can also use specialists at the central facility for remote consultation. Curative care gives high financial returns, but a pre-agreed volume of delivering preventive care is a prerequisite to remain in the network, which means that if the network providers do not deliver services like family planning, antenatal care, or immunization, they risk being dropped from the network and forfeit the opportunity to earn from curative care. A sophisticated management system interlinks all the networks and enables financial transactions between them. The project also provides strong rural marketing support.
I just skip this in the interest of time. Whoever are interested can always visit at our stall, which is stall number 35. I'll just wrap up in 2 minutes, basically giving the summary. The network grew from 5 centers in year 1 to 30 centers in year 2 and 128 centers, which is the last year's number, in year 3, to present 180 centers, including the Bihar project, reaching 3.6 million population. Now the expansion of this project is going on under Bill and Melinda Gates Foundation support for 28 districts in Bihar, covering 7 crore population, with about 1,500 such village centers and 15,000 such operators covering so many villages. There are more than 100,000 paid consultations in the last year alone, and the healthcare is available locally at less than $1 USD, and 75% of the time the patient gets taken care of there and then doesn't have to travel to the next level. And we have more than 40% repeat ratio, which means at any day if I get 10 patients, more than 4 are actually coming in who had visited earlier. So that really shows. So finally I will end this with some observations. Using technology at the primary care level significantly reduces unnecessary escalation to the secondary care level. Of course, we are trying to bring down the current 25% referral also by introduction of new diagnostics, which will take care of another 15% or so. The appropriate technologies that have low infrastructure and skill set requirements can ensure safety and quality, can enable local healthcare models. That is what is our belief. These are again the low cost in the long run, rather than something that we think of only of today, but overall in terms of wellness and management as well. The healthcare financing mechanisms like RSBY, which has recently been introduced, exploring inclusion of technology-driven primary care models can result in significant improvements in efficiency and saving. And that can actually trigger various other models, financial models in the whole process, is what our belief is. And public-private partnership basically has a very, very good opportunity to deliver quality rural healthcare affordably, considering various strengths of various partners in this world. So with that, I end my presentation. Thank you so much.